Next, Carolina, right? Carolina was a very brave study. Why do I say brave? Because these guys, linagliptin, DPP-4, decided they wanted to compare how they do against sulfonylurea. So they were having what we call an active comparator. One arm, linagliptin. One arm, sulfonylurea, glimepiride. Because glimepiride is the only sulfonylurea that's good in America. So they can't use gliptazide. It's not available in America. And they then recruited these two arms and randomized these individuals. So you must remember, there was no crossover at all. This means DPP-4 and only DPP-4. This means sulfonylurea and only sulfonylurea. There's no patients who are added on sulfonylurea in the other arm. Alright? So then they were able to look at how safe linagliptin is and how effective it is against a sulfonylurea glimepiride. So this is, to cut a long story short, very long study, very impressive study, and this is the endpoint for MACE in patients on linagliptin, and this is on sulfonylurea. So what do we take from that? It's not to say that it is a negative trial, we just say that there's no signal for cardiovascular danger in patients with cardiovascular disease or high risk if you give linagliptin as well as or glimepiride sulfonylurea. But some of you will say, wow, so much effort wasted, not wasted, right? Because if you look at the details, right, of hypoglycemia, then you see a difference. The difference being that those patients who were on glimepiride had a much higher rate of about 80% higher chance of having moderate or severe hypoglycemia compared to the individuals who were on linagliptin. Oi, not a very, sort of like, don't care. Hypoglycemia is very frightening. So next you say, moderate hypoglycemia I can tolerate. I don't have to worry. I worry about severe hypoglycemia. And here we are. The smaller numbers of severe hypoglycemia, but again, you can see 85% less chance of having severe hypoglycemia, almost nothing happening in the patients on linagliptin versus those who were on sulfonylurea. So very safe in terms of causing severe hypoglycemia. Some of you will think, still not satisfied. I want better. Right? Here we are. If the hypoglycemia is bad enough to need this patient to be admitted, hospitalization due to hypoglycemia. And here again, you can see the numbers are even smaller, but you can see certainly a very safe drug. When you and I treat our patients with diabetes, I want to see a safe medicine, a medicine that I don't have to worry, I can go to sleep at night. I don't have to worry this patient will wake me up or the hospital will call me and say, doctor, this patient now already fainted because the patient is having hypoglycemia. We can sleep without having any worry. Okay? This is Carmelina just to again tie in together the fact that linagliptin has two cardiovascular outcome trials, not just one. Carmelina came out 1 year ago and also showed us that in fact linagliptin in a higher risk individual with longer duration of diabetes, 15 years of diabetes, right, it was still very safe when used in the Carmelina trial. Cardiovascular safety, right? So I would like to again emphasize it is important to you and me because it's the patient in front of you, in front of me, that I can say, Mr. So or Madam So-and-so, right? You are very safe in good hands because the evidence is that if I use it in a very long-standing diabetic patient with kidney disease, with heart disease, it is safe. I can also use it in slightly younger patients, but also with high cardiovascular risk, but don't have to have diabetes for so long. It is still safe, right? So this is very exciting data for me because as I try and get my patient's A1C down, right? I want to tell them it is safe, you don't have to worry. Last but not least, Rewind came out 3 months ago. This is dulaglutide. Dulaglutide, a GLP-1 medication, injection once a week, right? And you can see here, I'd like to perhaps mention to you that this was a very, very large trial, almost 10,000 people, but recognize that only 30%, 1 in 3 patients in that trial had heart disease. 70% had cardiovascular risk. So I would say that this has a large number of primary prevention diabetic individuals. And again, not very young, and they have had diabetes for quite a while. And you can see a very significant reduction, less MACE endpoints when they were given dulaglutide once a week versus placebo. Yet another GLP-1 trial to show me, and this is probably the only primary prevention trial that is positive, right? So let's look. Of all the drugs, I will have to say GLP-1 looks stronger than the SGLT2s. Leader trial, positive. Sustain trial, positive. This is all MACE outcomes. The Excel trial, just out, not quite positive, and Harmony, all positive. 4 out of 6 trials with GLP-1 are positive, with the one that is the most recent, the one I just showed you, with the largest number of what I call primary prevention. So let's just look at all the trials. In totality, the MACE outcomes for SGLT2, you are familiar. EMPA-REG, CANVAS, DECLARE. EMPA-REG was positive for MACE benefit. CANVAS was positive for MACE outcome. DECLARE missed the boat. DECLARE does not have primary or secondary prevention data. So now, we as clinicians, I as a doctor looking after my diabetic patients, am very excited. For the first time, 5 years running, we are now having 6 drugs that can what we call disease modifying. What do you mean by disease modifying? Changing the course of the disease. You can actually lower the chance that that patient will have a cardiovascular event compared to what you expect if the patient doesn't bother about their diabetes. Right? And I like this small analysis that came out of the EMPA-REG trial. What they were able to show, x-axis, how old the patient was. Y-axis, the treatment difference, if the patient was on EMPA versus placebo, and the life expectancy change if they were given EMPA versus placebo. So let's just track one possible individual in that trial. If that person was 60 years old, recruited into the EMPA-REG, was given EMPA instead of placebo, that patient would be expected to have an extra 2.5 years of life compared to if he was given placebo. Whether it's a male or female, I'm just using it as a standard. Okay? So I think this speaks to me as a doctor that if I am able to have this patient has established cardiovascular disease, given EMPA, that I might expect this person to live longer because of the effects of the drug. So therefore, it's not surprising that the new trial, the new algorithms, the new management recommendations have changed, right? And this is the latest one that just came out, as I said, literally 2 days ago. 2019 update, but printed just 3 days ago, meaning it only affects us for 2020, right? And look, not very different from before, right? I'll just explain to you what were the differences, and I'm very happy to see this. Why? Because I don't quite believe, or rather embrace the ESC guideline, which maybe Professor Chi will try to defend, right? So, first line still remains informing, right? And then subsequently, slight differences. They put in that middle level, which is red in color, high risk or established cardiovascular disease. And I think I agree with that. But metformin, still first line, comprehensive lifestyle, still first line, right? But what I want to, again, this is new. In the new guideline algorithm, consider, irrespective, don't care what the A1C is, you might want to consider addition of these drugs that have been found to be benefiting. And they say indications of high risk is more than 55 years old, either left ventricular hypertrophy or some form of modality that shows them that they have some kind of peripheral arterial disease. So you must have this indication, not just because they have high blood pressure, diabetes and cholesterol. That doesn't put them, in my mind, in high risk category. And they have also mentioned very clearly that these drugs should have a label indication for its use. What do I mean by that? Here is from the same guideline, and they have clearly decided for cardiovascular effect, established cardiovascular disease, benefits seen with EMPA, benefits seen with CANA. Do you see DAPA anywhere? This is 1 year after declared CANA. So they have not agreed with the declare, the declared results is negative. They have not said declare or DAPA is effective for established cardiovascular disease. And this is exactly how it pans out. That the US FDA has given approval for EMPA. Similarly, I'm glad to show you that this is the Vietnamese recommendation and approval for cardiovascular death prevention in type 2 diabetic patients. So I just show this little cartoon. Some of you may not understand this cartoon, but this is the Grim Reaper. You know the Grim Reaper, the guy waiting for you when you've gone to either heaven or down there, right? And so he tells this person who's still walking the streets of maybe Ho Chi Minh, like, you've been on my kick the basket list, but why are you still walking here, right? You're not there yet. And I say, right? Maybe because he's been on SGLT2 and he's still alive. I like that. But I would like to perhaps mention to you, I will not use SGLT2 on every single patient that I manage, and I hope you also do not do that, because the CVOTs were recruiting patients who were very high risk, either already have target organ damage or very high risk. So please remember that these patients in the trials were very near the edge of falling over or having a cardiovascular event. Not the 35-year-old, not the 45-year-old who's walking there laughing at you, right? He has very high risk, very near the edge, so that there will be lots of events, all right? But not too far away. The young people who don't have heart problems or having cardiovascular risk, because their risk of events are going to be very low, right? So remember, these cardiovascular outcome trials only important or emphasize to those who are very near the edge. But not all my patients, and I'm sure you agree with me, not all your patients have that same level of risk. And you cannot just, so I suppose, generalize it to all the patients that you manage. And therefore, I'd like to spend some time talking about all the type of patients that I see. Why? Why is it important for A1C to be improved? Because we know A1C translates to poor, higher risk of complications. And what makes this person hyperglycemic in the first place? What makes them diabetic in the first place? All these things that you've heard before, you know, I'm not going to spend a lot of time discussing it. But SGLT2s only work on one of the 8 pathophysiological processes that cause hyperglycemia. So it makes sense that if you and I want to improve the glucose, then we will use medicines that will work on these problems in order to get the A1C down. Don't just be like my cardiology student, who's now a professor, and I'm very proud of him, saying, oi, I just give SGLT2 and I'm done. Not, oi, not done yet. A1C is still important, right? Why? Because improving A1C will give me all these benefits that you are familiar with, right? Why? Because we know that diabetes type 2 is progressive. The longer they've had diabetes, the more medicines I have to give them in order to make that glucose go down. But it doesn't matter that everybody doesn't have to be like that. We can actually flatten out the A1C curve. We can actually make their A1Cs go down and stay down. The only important thing is that we actually give them more medicines when it is necessary. So I show this cartoon. This cartoon tells me one thing. This is a medicine that I can use as a security blanket. Again, like I say, it is like I can give this medicine, immediate proof, just take it, as long as you take it, it works. Alright? What medicine is that? Is that metformin? Is that? What else it can be? It is DPP-4. I've told you. Right? Very easy to use. It is effective. It is effective on the beta cell, especially in the patients who are slim. It doesn't cause a high risk for hypoglycemia. I've shown you Carolina. I've shown you Carolina. Right? It is effective in renal impairment. It is safe for the heart. Right? What more do you want? I want more. I'm greedy. What I know is that in this analysis, that when the patients were more Asians in the study, the A1C reduction is higher. More A1C reduction versus those where there were more white people, there's less A1C reduction. And that's what I see in my practice as well. That when I see a younger patient who is slimmer, the DPP-4 is very effective at lowering the A1C. And I'm very, very excited with that data. And here is verified. You may have heard the verified result, right? Newly diagnosed diabetic patients who were then recruited into this verified study, and their primary endpoint was to see whether or not there was how fast they failed control, right? Using vildagliptin. The definition for time to failure is failure to keep the A1C below 7%. So this is where the verified population sit compared to all the other trials. The other trials, A1C were higher than 7. The other trials, this x-axis is number of patients in terms of duration of diabetes. Verify is very early on, and A1C was not high at all. They had two questions that they wanted to answer. If I give my patient metformin alone, how fast will the A1C increase? If I give my patients DPP-4 plus metformin together as an early combination, how fast do they fail? And then the second one, which is even more important, because after all, if you think about it, this is not fair comparison. It's one medicine versus two medicines, right? Here, they are looking at time to second failure. That means equal. When this patient in the metformin monotherapy added vildagliptin and they fail, versus those who are started on 2 at the same go, and when do they fail? So this is how they worked out their protocol. The protocol was recruit and randomize, metformin alone or metformin plus vilda. At the end of 6 months, these patients who were failing metformin alone were able to add vildagliptin. That is first failure. First failure, therefore, if you add vildagliptin on the monotherapy metformin arm, that is initial primary treatment failure. At the end of 12 months, then the patients in both arms, vilda, metformin, either metformin alone or metformin vilda, and they still A1C is higher than 7%, they were able to add a third drug, in this case insulin. And from 12 months onwards, this is classified and defined as second treatment failure, right? So primary treatment failure is one drug versus combination at the word go, all right? And you can see here that in fact, metformin is not a very good drug at keeping patients at A1C below 7%. And you can see that the early combination is able to prevent patients from going above 7% by an extra 2 years.